Hello, this is Dr. Grant Cooper from Princeton Spine and Joint Center. In today's video, I want to address a question that I received from someone who must be another clinician who asked how to best manage patient expectations, particularly at a first visit when it comes to imaging. This is a really interesting question, and it's one that as specialists we deal with it all the time, but I've never actually been asked that specifically. And when I reflect on that fact, with all the teaching and the talking that I do, I'm kind of surprised it's never come up, except in indirect ways, and that happens actually quite a bit. Now, the question put another way comes down to that patients often come to a doctor and they have a pain and they want a picture right away so they can find out what's really going on or see what the problem really is. But often getting that picture is just not appropriate because it's not going to help with the treatment. So how do you articulate this? How do you manage that interaction? And what's the balance? As a former psychology major in the way distant past, I'm excited to dive into this. But first, I need to remind you to please remember to like this video and subscribe to our channel so we can continue to grow and reach and hopefully help more people. So to the question at hand, from the patient's perspective, I can understand, and I think we can all understand, that there's an obvious tendency or predilection to want a picture of the problem, some sort of picture, any picture, an X-ray, an MRI, or any other kind of picture so that we can see their problem and know what's going on. This is so understandable precisely because much of our lives, in fact, most of our daily life works that way. If a car engine stops working, we can pop the hood to have a look at the engine, unless you have an electric vehicle. If your dishwasher breaks, you can pull it apart, you can look inside. If a building is unstable, you can look at the foundation and understand what's going on, etc. We're used to being able to use visual inspection to tell us exactly what's going wrong with something, right? If my car is jolted and it bounces up and down all of a sudden on the road, I can look at the road, see the pothole, and I can understand what just happened. It makes sense then that if your back or your shoulder or your knee or your hip hurts, you should be able to just look inside and see what's really going on. The trouble with that idea is that unfortunately, when it comes to our bodies, they just don't work that way. If they did, life would be a lot simpler for all of us to be sure, but they don't. Our bodies are just more complicated than a car's engine. My wife is the same type of physician as me, and an undergraduate, she was a dual major, and one of her majors was in biomedical engineering. And she likes to tell patients, particularly her engineering patients, that she would like to be able to describe their body as if she were describing a building or a mechanical structure. But while there are similarities, there are also vast differences that preclude that sort of simpler analysis. With a body, there is the gross anatomy that you can in fact see that on a picture, whether that's an X-ray that will show you the bone and air, or an MRI that shows you not only the bone but the soft tissues in greater detail. But there's also so much that an MRI or any other imaging modality will miss, such as the biochemistry, small fiber nerves, neurotransmitters, and not to mention the amazing interplay of the biomechanics and the complex interactions between all of these factors, that at the end of the day, the picture of the gross anatomy gives you some important information about the joints, the soft tissue, the nerves, the spine, but it only gives you some information. The picture can't see the biochemistry, it can't see the small fiber nerves, it can't see the neurotransmitters, and nor can it see the delicate live dance that goes on between all of those factors all the time. So as a result, pictures can actually be terribly misleading. If we spent all day treating every problem on a picture, we would never stop performing surgery on every joint in every body. It would, obviously we're not going to do that. This is the reason that one of the most important lessons in medicine that we teach is that we need to be treating people and not just their pictures. Consider some statistics to put things in some perspective. On MRI, 1 in 5 people will be seen to have full thickness rotator cuff tears in their shoulder, but have no shoulder symptoms. In fact, more than half of everyone over the age of 80 with no shoulder symptoms have full thickness rotator cuff tears. 80% of everyone over the age of 70 who don't have shoulder pain have partial thickness rotator cuff tears. 44% of people with no hip pain have hip labral tears. Over 60% of people with no symptoms who are on average 40 years of age have meniscus tears in their knee. 76% of people with no knee symptoms over the age of 60 have meniscus tears. 70% of the general population with no back pain who are under 50 have degenerative disc disease, and more than 90% of people who are over 50 and have no back symptoms have degenerative disc disease in their spine. So, really no joint makes it out looking completely pretty as we age. But just because we can see all of these degenerative changes on, ever better imaging studies doesn't mean that these changes will ever lead to any symptoms. Now, it doesn't make them irrelevant. The picture helps fill out the whole clinical context, and the picture should be used as one important piece of the puzzle, but just one piece. So all that is to say that pictures have a place in the diagnosis and treatment of patients, but they aren't the end-all and be-all of arriving at a diagnosis. And to that end, you can see that there's a tremendous amount of background noise whenever you order an imaging study for musculoskeletal pain. So for this reason, we can now circle back to the question of when should you order an imaging study. I've covered this in detail in other videos going body part by body part, but in general, I favor getting imaging studies when they're going to inform and direct the next step in patient care. And now we can get back to the real question, which was when you first see a patient, this may mean that you don't need an imaging study because most people at first are going to be treated conservatively, regardless of what you may or may not see on an imaging study. Now, obviously there are exceptions to that, but we're talking very generally here. So what do you do when this reasoned evidence-based approach to ordering imaging studies runs headfirst into patient expectations? The patient expectations that they want to see what's going on. This confrontation, as it were, is made more challenging by the fact that often this expectation to get a test in order to see the problem occurs at the initial visit when you haven't had a chance to earn and build up extra trust in that relationship over time. So how do I personally handle this situation? Well, if it's a patient that I know well because I've treated them before for other problems or because I've treated their family members, then honestly, it's always a lot easier because they already know me, they already trust me and trust my judgment. When it's a new patient or a patient that for whatever reason might come into the situation with less trust overall in medicine or doctors, then it's always going to be more challenging. But either way, I always do my best to explain my reasoning for everything that I want to do or not do. So in the case of imaging studies, I explain why I do or don't want an imaging study. Let's take the case of why I don't want the imaging study, because honestly, it's very rare that I would like to get an imaging study and the patient doesn't want to get it, right? It's much more common that there's no need for the study, but the patient still wants it because they want to see the problem. So what I do is I explain why no matter what we would see on the imaging study, it won't change their care. And so for that reason, I don't think that it's worth the radiation, the time, or the expense to the patient. Often I quote them the sorts of statistics like I was just talking about a moment ago to illustrate that even though we may see arthritic changes or what have you, it wouldn't mean that this was the cause of their pain. I explain that bodies unfortunately just aren't that simple. And I also try and explain at the outset when we would plan to get an imaging study. For example, if the patient were still having symptoms after physical therapy or still having symptoms at this or that time, etc., then we would want to get an MRI or whatever that study might be. And usually if I take a few minutes to explain my thinking and explain that it's not that I'm trying to keep an imaging study away from the patient or that I'm trying to do the insurance company's work of driving down costs of the patient, which I have found is in the back of some patients' minds over the years, but rather that I don't think the imaging study is worth the time or the trouble on behalf of the patient to get it, precisely because the results of the study won't be changing their care. Usually then the patient is happy with the decision and they understand. If the patient still wants the study, then I try to figure out why they want it. Sometimes the answer to why the patient still wants the picture is because they're just very nervous people and they know that about themselves. And having that film will just help them sleep better. If that's the case, I think it becomes a real judgment call about what to do for that patient. If it's an MRI that we're considering or an ultrasound, honestly, I'm much more likely to want to get the test for them in order to put their mind at ease, since I think that does serve a valuable purpose in terms of their mental state in those instances, and there isn't any radiation involved with those tests. Likewise with an x-ray, while there is some radiation, it's so little radiation that if a patient really will sleep that much better having had the x-ray, then I'm often okay with that. Where I tend to draw a hard line is with CAT scans. With CAT scans, where there's about 100 times the radiation of an x-ray, I've never ended up getting that for a patient unless I thought that medically they really needed it, because I do think that that's enough radiation to be causing real harm to the patient. So if they need a CAT scan, I'll definitely get it. But I wouldn't just order that just to put someone's mind at ease, because I think that would be hurting them to do so. And I would just explain that to them. And in all my years of practice, I've never had a patient have a problem with that once I've taken the time to explain it to them. Okay, that's it. I hope you've enjoyed this video. I hope you've learned something. If you have enjoyed it, please remember to like this video by clicking on the thumbs up and subscribe to our channel. I'd love to hear your comments on what I've said in this video as well. If you have any questions or comments for me, you can leave them in the comments section, or feel free to contact me at drcooper@princetonsjc.com. Thank you very much, and I'll see you in the next video.